Welcome. Thank you all for being here. I know we still have people logging on, so I'll just get my intro out of the way so we can get our presentation started. My name is Carrie Fogel. I'm the Senior Director of Development and Foundation Relations here at the Ioneer Foundation. And as most of you know, we host these webinars every other week, and we feature different topics in vision loss, hearing loss, head and neck cancer, sinus allergy balance, and all kinds of related conditions of the eye, ear, nose, throat, head, and neck. So today we are focusing on the head and neck, the who and the where of head and neck cancer specifically, hosted and presented by Dr. Angela Mazul, one of our newer faculty members to join our Department of Otolaryngology here at Pitt. So we're thrilled to have her kind of making her webinar debut today. A quick reminder to submit all questions. We encourage questions. We hope you have a lot of them. You can submit them to the Q&A box at the bottom of your screen, and I will moderate the discussion with Dr. Mazul following her presentation. So I'll hold all the questions to the end, but you can feel free to ask them at any point during the presentation whenever they occur to you. And as always, if you miss parts of the webinar or you would like to send it to somebody who you might know or just access it after the fact, we always post them on the Ioneer Foundation website in the next day or two. So here's information for our speaker today, Dr. Angela Mazul. Dr. Mazul is a dedicated cancer epidemiologist, and she specializes in head and neck cancer and HPV. She has more than 50 peer-reviewed publications and has presented her research at many international conferences. She's also an active member of the scientific community and serves as an editorial ad hoc reviewer and mentors many clinical research trainees, medical students, fellows, and residents. Dr. Mazul is a member of the Society of Epidemiologic Research and the American Society of Preventative Oncology. So we're thrilled to have this new topic for us. I hope we have lots of questions. I have many myself, so I will go ahead and turn it over to Dr. Mazul.
Thank you so much. I am very excited to be here. I love talking about head and neck cancer epidemiology. I'm going to say this multiple times through this talk. I am not an MD, I'm a PhD, but I do work with a lot of clinicians, and I will be touching on some medical things. But so yeah, just as a heads up, I don't know much about the actual treatment of head and neck cancer. But let me start my timer. So yeah, as Carrie had said, I came here about a year and a half ago. Love being at Pittsburgh and have really started a pretty good research program here, and I'm very excited. I am one of the few cancer epidemiologists, and the amount of support I've gotten from the department and the Ioneer Foundation has been fantastic, and I'm very excited to present what I have done. So I'm going to cover three major points. The first one is just head and neck cancer epidemiology in general and some of the background. Then I'll talk about my personal research and what I'm interested in, and that's head and neck cancer disparities. And that's who gets cancer and where they live and how it's important. And then some of the next steps. So what are the next things I'm going to be working on in the near future? So what is epidemiology? I really liked it pre-COVID. People would be like, what do you do? And I'm like, I'm an epidemiologist. And they're like, do you study skin? Can you look at this thing on my skin? And that was pretty nice. And then over here on the right, we have the COVID. That's the COVID virus, COVID-19. And all of a sudden, epidemiology became this very, very big thing. And what epidemiology actually means is it's the study of what befalls people. And so it's the study of diseases, the study of the disease state, what is causing a disease, and all of these things, different risk factors and things like that. How can we prevent it? How can we keep disease from not being as bad? Over on the right over here is a map from 1958 from John Snow, and he is a doctor in London. And this is one of the first examples of epidemiology in use in the modern era. Each dot on this map represents cholera and a cholera outbreak that happened in London. And if you look closely, there are X's on the map, advancing. Here, some of them are circled. And pretty quickly, you can see that all of the cholera cases are around one X in the center, and that is the Broad Street pump. And so what Dr. John Snow ended up doing is taking the handle off of their pump. So he was one of the first people to really understand germ theory, so how diseases are spread. He also used statistics to show that the company that supplied this pump, if you drink at this pump, you're 14 times more likely to get cholera than if you drink at the other pumps. Now, the thing about statistics, and we see this with the COVID-19 pandemic as well, is that they're not always perfect. You're 14 times more likely, but there are plenty of people who drank from the Broad Street pump and didn't get cholera. And there are plenty of people who probably drank from these other pumps and got cholera. So it's not always 100% association. It's never 100% in epidemiology. And I like this photo. This was me at the Broad Street pump in 2022. They had moved the Broad Street pump. The handle is still missing. And this was during the COVID-19 pandemic. So I was wearing a mask. You see the hand sanitizer in my bag. It was, from one pandemic to another. And it highlights that in the last 170 some years that while our medicine has changed and everything is moving, that there's still diseases in humans. And this is infectious diseases, but all the same logic applies, right? We're interested in what is causing disease and how can we mitigate it. Now, we can no longer take handles off of pumps, but what can we do to help prevent disease within the general population? So I am interested in head and neck cancer. It is the cancer, I always say it's cancer from your lips down to your throat, like your larynx and your voice box. What drew me to head and neck cancer is its complexity and its location. So here I am giving a talk, I'm speaking to you using my tongue and my voice. And so if you get cancer in this region, it's difficult to speak. And same with eating. When we hang out with friends, we're like, let's go grab a cup of coffee. And if you can't eat and you can't speak, it can cause a lot of problems in someone's life. And while it is not the most common cancer, it is one of the cancers with the highest rates of sequelae at the back end, so of problems that people can have after cancer treatment. So in the United States, about 71,000 people are diagnosed with head and neck cancer, and about 16,000 people die of this cancer. This is in 2024, the estimated number. So not that many, or not that, it's still a lot of people, but of the remaining people with cancer, they still have to live with a lot of the problems. I don't know if anybody saw the new Top Gun movie with Val Kilmer. So he had HPV positive oral pharynx cancer. And in that movie, he couldn't really speak all that much. And so that kind of gives you an idea of what it's like to live with head and neck cancer. And so going back to the figure, I don't know if you can see my mouse, but it's the mouth, the throat. It includes the nasal cavity as well as the larynx. It does not include like the esophagus and the trachea. So not this bottom part, but this upper part here. So the way I like to think about cancer is across a continuum, and to break it up into different pieces. And I'm interested in across this whole continuum of cancer. So there are 6 discrete blocks that I like to think about it, and the National Cancer Institute does as well. This has been around since the 1970s. And so the 6 groups are etiology, prevention, detection, diagnosis, treatment, and survivorship. And I've done research across this continuum. And first I'm going to give some background and then I'll talk about my research. So first is etiology. So etiology is what causes disease. And in head and neck cancer, there are 3 main things that cause big things. There are smaller things, which I'll touch on, but 3 big things that cause head and neck cancer. The first obvious one is smoking. The next one is alcohol. Fun fact about this photo, I just had a baby last year, and I moved to Pittsburgh while pregnant. And when she went into daycare, my husband and I were like, let's go out and grab a drink. And so this is my first drink I ever had in Pittsburgh, was this photo. We went somewhere, I don't even remember where anymore. We went somewhere downtown and it was very, very fun. But it is also a risk factor for head and neck cancer. And then the last one is HPV. So about 72% of head and neck cancers are caused by either, or thought to be caused by either smoking or alcohol. And if you have both smoking and alcohol use, it actually dramatically increases your risk of head and neck cancer. People who smoke cigarettes have somewhere between 5 to 25% times the risk of head and neck cancer compared to somebody who doesn't smoke. So the vast majority of head and neck cancers are caused by smoking and drinking to a smaller extent, but if you definitely have them together, it does increase your risk of head and neck cancer. I bring up HPV because now HPV is causing a dramatic spike in head and neck cancer incidence, or the number of cases that are diagnosed every year. So oropharynx cancer, which is the cancer of the throat, about 90% of oropharynx cancer is caused by HPV now. And so it's really changed the face of head and neck cancer. And people with HPV positive oropharynx cancer do tend to survive longer, which is great, but there's just more and more people being diagnosed with HPV positive oropharynx cancer. And it's actually overcome cervical cancer as the #1 type of cancer caused by HPV, which is important because it brings me to the second part of our cancer control continuum, which is prevention. So prevention is probably your best bang for your buck as far as cancer is concerned. You want to prevent it before it even becomes a disease, right? And in head and neck cancer, there's one big way of prevention, and that is HPV vaccination. I'll talk about this a little later in my research as well. Our vaccination rates aren't great. Good news, though, is that the type of HPV that causes oropharynx cancer is covered in the Gardasil vaccination. So if you get vaccinated, it should prevent HPV positive oropharynx cancer. So this is my, I guess, push for everyone to be thinking about HPV vaccination. Our rates aren't great, but hopefully we can get those up soon. The next one is detection. And here I'm using examples that are outside of head and neck cancer because we actually don't have great detection methods. So when you think detection, we're thinking mammograms, we're thinking pap smears, colonoscopies. There's actually lung cancer screening among people with lung cancer. And this is very important because the earlier you diagnose cancer, the easier it is to treat. So if you think about colonoscopies, if you get a colonoscopy done, they take out the polyps, and that's much easier than cancer treatment. It doesn't hurt. You're more likely to survive. My dad actually, my dad's whole family has very high risk of colon cancer, and he's the only one in his family who hasn't been diagnosed with colon cancer, but he goes for screening very often and gets his polyps taken out. And so it's important. And you think with the mouth, it should be easier. And at the dentist, they do screen, but you do have to go to the dentist to do the screening. And so this access becomes an issue as well. And again, I'll talk about that a little later, but you do have to go and get screened. There's also some research that I'm doing here, or not here, that is being done about HPV blood tests. So because HPV positive oropharynx cancer is becoming more and more common, there is some screening that is occurring on blood tests to see if you have HPV, which puts you at higher risk. And they're following them to see if maybe they will get cancer, then we'll have some early detection. So this is an area of research that is moving quickly. And yeah, hopefully we'll have a screen soon. But for right now, there is no screening or early detection for head and neck cancer. So diagnosis, we all understand it's getting diagnosed with head and neck cancer. And these are incidences and mortality in the whole world, so not just the United States. But across the world, this includes thyroid. In some places, thyroid is endocrine. In other places, thyroid is under head and neck. And this is through the World Health Organization, so they classify it here. But across the world, the incidence of oral cavity larynx are pretty high. It's interesting, it's ongoing research why HPV is more common among developed countries. So in Europe and in the US, HPV positive oropharynx cancer is very common, while in other locations such as Africa or South America, it is less common. Nasopharyngeal cancer is more common, and we'll see this maybe later. Nasopharyngeal cancer is more common in that's in the nose area, in the back of the throat, where your nose meets your throat, is more common in Asian countries. But even though the incidences here of oral cavity are low, the majority of mortality is up here in oral cavity cancers, and they still remain pretty high. Thinking about diagnosis, since we don't have a screening tool, how patients get diagnosed is very different, right? So some patients if you think you go to your doctor, a lot of people present with, there might be something weird in their mouth or maybe a lump in their throat. And then you go to your primary care physician, your primary care physician is like, you should probably see a general ENT, right? And then you got to make your appointment to go see the general ENT. General ENT is like, this might be cancer. And then they give you a referral and you're here at UPMC. And so going back to my disparities research, just for everyone to think about a little bit, if you don't go to your primary care physician every single year, or if you don't go to your dentist twice a year, you don't get your mouth looked at, you might take longer to get diagnosed than you get diagnosed at a higher stage. So kind of a little, just a little food for thought with thinking about like how you get from thinking you might have cancer to actually getting diagnosed from cancer is a pretty important step in all of this. Don't need to read this. This is one small piece, is oral cavity cancer, so cancer of the mouth, high stage oral cavity cancer. This is how treatment is determined. Not an MD, but it's complicated. And these are guidelines, and this is again for one small stage. And at the beginning, you get clinically staged, then you get surgery, and so your surgeon needs to talk to your radiation oncologist. So you go get radiation afterwards, and then you also get chemotherapy. So your surgeon needs to talk to your medical oncologist, needs to talk to your radiation oncologist. So that's 3 people for just cancer treatment. And according to the NCCN, this is the people who come up with these guidelines, there's also timing that needs to be involved. So from diagnosis to surgery, we would like to get you into surgery after 6 weeks of diagnosis. After you finish surgery, we would like to get you to chemoradiation within 6 weeks. And then once you start chemoradiation, we would like you to finish chemoradiation with 6 to 7 weeks. And so you're on this pretty like quick timeline to get through your treatment. And there is evidence that if you don't adhere to these timelines, that your survival is highly impacted. And this is a study I did a couple years back that just shows the red line here at the top are people who adhered to cancer treatment and to radiation specifically, and their survival is actually much higher. And the less you adhere, this is overall survival. So here at the top, survival is still pretty low, but it's probably around 70%. But if you don't adhere and it takes you a long time to complete your radiation, it's less than 50% that you may survive your cancer. So making sure that people adhere to cancer treatment is very important. So treatment is huge when it comes to survival and making sure people finish on time. So there's almost 500,000 head and neck cancer survivors out there. Again, don't need to read this, but this is a head and neck cancer survivorship timeline. I talked about having cancer treatment. When you get radiation to your throat, you have trouble swallowing, you have trouble speaking. If you have surgery, parts of your tongue and your jaw might be missing. So there's lots of physical therapy, occupational therapy, and speech and language pathology to help you gain your life that you had similar prior to having cancer treatment. And on top of all of this, head and neck cancer patients, you also are more likely to have other outcomes such as stroke or heart attack. So also working with your primary care physician to make sure your treatment is not degrading your quality of life too much. The good news for all of this is that here at the University of Pittsburgh, we have one of the best survivorship clinics out there. And it's actually what really drew me here. So Dr. Marcy Nielsen and Dr. Jonas Johnson run our survivorship clinic here, and they do a fantastic job of making sure people have a primary care physician, of making sure that they see speech and language pathology and dentistry and everything that is after the fact. So it is important to think about, yes, you have survived your cancer, right? Now what? And making sure quality of life is high. So into what I like to study, which is, I think about the who and where, which is somewhat epidemiology, but also who gets head and neck cancer, right? I talked about all of these risk factors, but I like to also think about disparities and what about head and neck cancer, not just who gets it, but survivorship and treatment and all of that is uneven based off of who somebody is or where they live, right? And this is all under social determinants of health. And with social determinants of health, it's very, very complicated. Again, this is a huge figure. I like to do big figures to show how complicated things are. But when we talk about disparities, it's not just black, white. That's probably the easiest one to think about, but it's rural urban. People who live in rural communities are more likely to have air pollution. They're less likely to have, like they have to travel a long way. So transportation becomes a big problem. And coming into Pittsburgh isn't easy if you live 2 hours away. We could talk about built environment, which is up here, which is what I'm very interested in. If you think about our Pittsburgh neighborhoods, the Hill District is a pretty poor district. From an access standpoint, they're just up the hill from UPMC, especially where Eye and Ear is located. But there's still lots of access issues that extend beyond proximity. And how do we measure these almost unmeasurable things? And that's what makes me so excited about epidemiology, is that we study humans, and humans are complicated. And we study these things that aren't measurable. In my lab, I have a couple of lab scientists who come in. They're used to using mouse models, and they're like, Dr. Mazul, like how do you deal with the uncertainty? And the statistics sometimes don't quite work out the way. You're not measuring what you actually think you're measuring. If we look at built environment, we might be trying to get at socioeconomic status, but we might actually just be measuring air pollution. And the thing is you don't really know. And I know from a regular person's perspective, and we see this during the COVID-19 pandemic, where we kept changing things because we're trying to model humans, and humans are complicated. And so, and then when we're trying to measure something as complex as what a socioeconomic status is, even something as complex as race, right? Race is something we've kind of made up in our head. There's no such thing as genetic race. And we just kind of put these humans into buckets. Someone can self-identify themselves as Black, but then other people might not see them as Black, or they might be white passing. And even something like gender, we see that, especially now with the Olympics that just happened. Some people have been women their whole lives, and then suddenly they have higher levels of testosterone. They didn't know this, so they're not allowed to compete, but they've always been a woman. So it's these fluid, complex things that we're trying to fit into buckets. And to me, it's fun, but I think I just want to just make sure everybody understands that when I talk about these things, we're talking about associations, and it's not quite set in stone. And as we learn more, they will continue to shift. So, etiology: smoking, alcohol, and HPV. So this is the smoking maps in the United States. This is a little old. I couldn't find newer data, so I apologize. Smoking rates in the US have been declining, but it is somewhat uneven. And what I want to really point out here is in the Southeast, in Georgia, outside of the city, outside of Atlanta, it's pretty orange. Appalachia right here into West Virginia, Kentucky, and even some of Western Pennsylvania, smoking rates still are very high. So these areas are rural, and these areas in the South, they're predominantly Black. So while smoking rates are decreasing, they're not decreasing evenly across all populations. And so when we think about how do we do smoking cessation, all of these, we need to be thinking more about specific populations. And one of the reasons why I like Western Pennsylvania is that it is a very, very specific population. So when we develop interventions, we got to be thinking about how do we develop interventions for Western Pennsylvania. Also, these areas tend to be lower socioeconomic status. And like I said, I'm interested in how your neighborhood and built environment with socioeconomic status, like how do you measure that? So the CDC has the Social Vulnerability Index. This was developed by the CDC to see if a county, if something bad happens, hurricane, tornado, if they're able to bounce back from this natural disaster. And they have 4 metrics: socioeconomic status, household characteristics. So if a county is very old or very young, a lot of single parent households, low English proficiency, they're less likely to bounce back, right? Same with a minoritized county. If it's a county of mainly minoritized people, then they're less likely to bounce back. And housing and transportation type, that makes sense. A lot of mobile homes, people don't have cars. I like this metric because it doesn't just work for just like natural disasters. You think of pandemic, right? So if there's a pandemic, how do we bounce back from that? Even what if a large portion of your population has cancer? Like it measures beyond just how vulnerable a county is for natural disasters. So I bring up all of this because this is a study I did with Dr. Sandra Stinnett here. She's a laryngologist. This is larynx cancer. There's a lot of colors on this map, but I really want to focus in on the blue. So the blue are poor neighborhoods, right? Low, like very high social vulnerability index and very high incidences of larynx cancer. And if you think back to the smoking map, and we're missing a bunch of states here, it falls in line with the high areas of smoking, right? And so our smoking locations do tend to be poor neighborhoods. And then not only are there high rates of smoking and they're poor, but they're high rates of larynx cancer. So there needs to be more resources poured into these counties to help bolster the, or just to help, not just help people get diagnosed with larynx cancer, but perhaps also smoking cessation. The other thing I kind of want to point out is this lighter blue. So this is high rates of larynx cancer, but not necessarily a high social vulnerability index. So the interventions there might be slightly different. Stay tuned. I am working on getting the Pennsylvania data for this. I'm pretty excited. We're going to do not just counties. Counties are pretty big. If you think about Allegheny County, we have it's very, very like there's some places that are a little more rural. There are places that are more poor, and so hopefully we'll be able to do a smaller neighborhood for Western Pennsylvania. So stay tuned. Maybe next year I'll update everybody. All right. Prevention is Gardasil. These are adolescents. Our HPV vaccination rates not great. Some states are extremely low. Some states are pretty high, but also not great. We really want to get, the CDC wants to get to 80%. I personally think it probably needs to be a little higher to really see a big change. But needless to say, there's lots of work to done. This is in adolescents. Ooh. This is the work I did out of the VA. The VA is interesting because everybody who seeks care at the VA has access to care. So you don't need to pay for it. If you want to get the HPV vaccine, the VA will pay for it if you're less than 26. And even with these veterans, you could look at the darkest ones are our highest rates, and they're still pretty low. And most of the states, we're looking very, very far from 80%. And all of these veterans qualify, 26 and under can get vaccinated. And our states with the biggest population, Texas has a lot. Florida does okay, but a lot of our big states we're missing, there's just not enough, there's just not high rates of HPV vaccination. So we're currently working with the VA to see if there are ways we can bolster HPV vaccination among veterans. Now, actually, if you could vaccinate up to age 45, you just need to have a conversation with your doctor, and you could have a discussion as to whether or not it's worth getting vaccinated up to age 45. So, like I said, it's the only way we could prevent oropharynx cancer, really any head and neck cancer right now. So we're really trying to work with the VA to get these vaccination rates a little higher. Back to incidence, we're talking about diagnosis. So this is my research again, it's all my research, but over here, we're going to start on the left is our, this is oral cavity, so mouth cancer rates. And as you can see, they're increasing. The solid lines are low socioeconomic status, and the darker line, or the dotted lines and the darker lines are high socioeconomic status. So this is showing oral cavity oral cavity incidence is increasing among white and low socioeconomic status people. And it's higher than high socioeconomic status. And the good news is among Hispanic and Black populations, they are decreasing, not that quickly, but the rates are going down. The high socioeconomic status Black population, it's like kind of plateaued. Among Asian populations, it's actually inverse. This is something I've been trying to see if I could find data on to see why this is the case. Why do high socioeconomic status Asian populations have higher rates of oral cavity cancer? I am not entirely certain right now, but we're trying to tease that out. I had mentioned stage before. Localized disease is you have a tumor and it's nowhere else. Regional is you have a tumor and then it's in your lymph node, so it's close. And then distant is you have the tumor and it's somewhere else. So I believe lung is really common, but don't quote me on that, but it is just not in this region anymore. And I don't want to, like, there's not too much here to really see, but some of the disparities can be somewhat interesting. So Black population, that this is having higher rates of regional disease, and the distant disease is very uncommon. That these bars are just basically showing we can't see anything because there's not enough people. All right, let's talk about treatment and disparities in treatment. So with treatment, this is a study I did with Dr. Evan Corboyas out of MUSC. And this is looking at, again, it's like social vulnerability, but it's called area deprivation index. It's another index. But the dark line is you live in a rich neighborhood, for the lack of a better term. This is a rich zip code. And the gray line is a poor zip code. I talked about treatment adherence, and this is measuring how much are people adhering. And if you live in a rich neighborhood, you are far more likely to adhere to getting radiation on time. If you live in a poor neighborhood, you're less likely to get to radiation on time. So it's very, when you get radiation, when you start, radiation is highly, highly dependent on where you live. And some of the next steps for this, like, why is this happening, right? We can't change where somebody lives. So why is this happening? I'm putting a grant in, hopefully soon, to study stress. So if you're more stressed, you might be less likely to really push to get things done on time. You have a lot going on. I just had a baby, a baby at like a year ago. And even just trying to like manage my life and manage everything, sometimes I have forgotten to make an appointment, or it's harder for me to keep track of everything. So you can imagine having a cancer diagnosis, and if you're already live in a poor neighborhood, you're already food insecure, you already don't have a place to live, adding a cancer diagnosis can kind of tip you over the edge, and it's hard to stay on time for everything. Lastly, I'm talking about survivorship. This is a study, again, I did with Dr. Marcy Nielsen and my postdoc, Mariana, who's a first-year intern, actually, in the Department of Otolaryngology. But all of the red dots are people who don't go to survivorship clinic. And I talked about how great our survivorship clinic is. And what we see here is people who live, and you can't tell closer into Pittsburgh, but people who live within the Pittsburgh area are more likely to come to survivorship clinic than people who live further away. That is what this line is showing. These are people who live in urban areas, and these are people who live in rural areas. About half to like 40% of our patients come to survivorship clinic, and we would like to change that. So Marcy and I have submitted a grant to study who is coming into survivorship clinic, and we're going to talk to them. And we're talking to people who both come and people who don't come, and to figure out what can we do to help our cancer patients come into survivorship clinic to really improve their life. Marcy has shown that if you do come, you're more likely to gain your speech back, you're happier. And so we really want to make sure our cancer patients are coming into our survivorship clinic, especially the ones who live further away and who might not have the resources of people who live close to the city. So going into future studies, I have a lab here, one of the few head and neck cancer epidemiology public health labs. I have medical students and graduate students who are working with me. We're going to look at diabetes, so I'm interested in etiology and the risk of oral cavity cancer. We're also going to look at oral health and your risk of oral cavity cancer. I have another student who is looking at access to ENTs. I talked about, well, how close you live to an ENT matters. So she has mapped out the ENTs in Pennsylvania and is calling them to look at their wait times. I talked about stress already. And I have another student who's interested in clinical trial enrollment. So we have a suspicion that people who enroll in clinical trials tend to be wealthier, tend to be whiter, tend to be more urban. But in Western Pennsylvania, there's lots of rural patients. So are they enrolling in our clinical trials, and working with a student and a radiation oncologist on this study? So thank you everyone for your time. I made it a little over half hour, so this is good. I'd like to just acknowledge my lab. It's a pretty big lab. They're all fantastic. Nanahawa, Mazat's my research coordinator. Rita is also someone who does patient recruitment for me. Katie is another epidemiologist, master's epidemiology who works with me. Mariana, who I mentioned, was a postdoc and is now an intern. And then Tasha and Tasia are medical students. So thank you, and I'll be happy to answer any questions.
Thank you, Dr. Mazul. That was really educational. You know, we hear a lot on these webinars, and just if you're, attend Ioneer Foundation events over the years, we hear a lot about head and neck cancer. We've heard and learned more about the role that HPV plays, and, the kind of trying to get the word out about the easy ways that you can prevent HPV from proliferating and causing cancer. So we're really excited to, always keep this at the top of mind as like a public health topic that we can influence, hopefully. You mentioned a lot of different things, but I was hoping, this is my own personal question, then I'll get to all the questions that we have in the audience. I'm letting a few more come in, but we already do have many. If you had anything to say about people, other types of people who may not be getting in for treatment or for their survivorship care, specifically people with intellectual disabilities, and maybe, and then any other like specific groups that you're looking at, not, people who are living in different neighborhoods, but also just like other specific groups that you were working with.
Yeah. So the intellectual disability one is very interesting, and there's very little study on that, and we are looking into it. We have all the data from UPMC, and we are going through and pulling out people with intellectual disabilities. And it's challenging, right? Because intellectual disabilities, while a lot of people will have a diagnosis of Down syndrome or cystic fibrosis or many of these other things, sometimes it's not in the chart. So that is a small thing we run into. And I have now tapped one of our many colleagues who do AIML to help us find people with intellectual disabilities. But what has been seen in the literature is that people with just any sort of disabilities, they're less likely to adhere to treatment. They're less likely, they kind of fall out a lot more. They don't go to survivorship clinic, even though they probably should be the ones who go to survivorship clinic the most. And we are working on trying to get our patient navigators to also help some of these patients. And the other part that I'm kind of interested in all of this are patients, I didn't mention this, but they tend to be diagnosed older. So many of the patients who are diagnosed are also in their 70s and 80s. And I've asked my person who does the AIML work to do like intellectual disabilities, but since he's already collecting all these data, to also look at cognitive decline. So people who come in, well, many people have Alzheimer's and dementia diagnosis codes, but what happens to people who are already kind of on the cognitive decline if they also tend to not adhere to treatment, also not go to survivorship clinic? And while intellectual disabilities is very big and they also need help, but maybe we could expand the pool a little bit and help people with other issues as we hit cancer diagnosis on top of aging, right? And as we expand this, there's also other people, like I mentioned, if you're food insecure, if you live in the Hill District and you can't get your groceries every week, like they also need help, but that's a different sort of, they just need help getting groceries. So it's not the same like patient navigation. Like I said, every intervention is different depending on your need, right? So if you're food insecure, then putting them with state or with a food bank might actually help people more than having patient navigation. So making sure your intervention is right for the population.
Well, thank you for speaking to that. That's just an area that I know you've been working on since you joined the team here at Pitt, and we're excited that you're looking into that, because it seems like those patients often are overlooked and are vulnerable for so many reasons.
Yeah, and hopefully, well, maybe I'll start making a list of what I could talk about next time, like Pennsylvania. How are we doing with Pennsylvania? And then maybe I could touch upon some of this. I'm pretty excited about like just even looking at it and some of the possibilities of what we can do. So,
well, great. We already have a follow-up webinar from today. So thank you. We have several questions related to the Gardasil vaccine, so I'll try to get through some of those. Is there, that of an ideal age frame that one should get the HPV vaccine to be most effective in preventing a head and neck cancer?
Yeah, it's before you get any sort of HPV exposure. That is the best time to do it. So before people have sex is honestly what it is. And that's why we recommend HPV vaccination so young. So CDC says you could start at 11 and down to 9. And the sooner, honestly, the better. And it works really well. And as far as we know, that you could keep it stays lifetime. The first clinical trial started in 2000, maybe even before, and they've shown really high HPV antibodies. So it is effective, and we should be vaccinating our boys and girls that young. I know it feels a little odd to be vaccinating against a sexually transmitted disease that young, but honestly, you don't know, right? And so it's better to get it when they're younger instead of once you're exposed. While it can still work, it is less effective. So you want to make sure you get it before. And since teenagers, I was a teenager, you were a teenager, you're not telling your parents everything. And so
Long ago.
yeah, long ago. So you should, it's better to do it before. And that's why we recommend so young. And I know it's uncomfortable, but at the same time, it's important because yeah, it's a tough disease.
Kind of zooming in a little bit on what you just said, how, we like to offer this vaccination at a younger age just to make sure it's maximally effective. We have another question about the pushback on parents, physicians offering the vaccine to, all children over the last, however long it's been offered. Has there been pushback from either parents, physicians, or like even the anti-vaccine movement that, has slowed the rate of the uptake of the Gardasil vaccine?
Yeah, it definitely has. And it's ramped up a lot post-COVID. So HPV has always kind of been on the chopping block a little bit. Some school districts have put it in as a required vaccine, and many times it has failed to go in as a required vaccine because of its sexual nature. And I put it in quotes because you can get HPV without sex as well. But it's uncommon, but it does happen. And so it has ramped up a lot. There's been some evidence, especially among adolescents, that HPV vaccination rates have decreased with this new HPV movement. And it's a little bit of a shame because the population where the HPV vaccination hesitancy or vaccination hesitancy is the most common is also where the prevalence of oropharynx cancer is the highest. So it's actually, if you think about it, it's among highly educated populations where there's more pushback, and among rural populations where there's more pushback. And HPV positive oropharynx cancer is more common among highly educated white populations and rural populations. So it is a little bit of a shame. And hopefully it's safe. It's a highly effective, highly safe vaccine. And so it is a little bit of, and it prevents cancer. So to me, cancer is extremely debilitating, and it's a cancer vaccine. Yes, it is an HPV vaccine, but we have it to prevent cancer. And I talk about head and neck cancer here, but cervical cancer, uterine cancer, penile cancer, like penile cancer is extremely rare, but it's pretty terrible. And so it prevents all of these cancers, and it is a shame that the rates are actually, they've plateaued, if not gone down, since COVID. So hopefully we can bounce back. I'm optimistic, but I'm an eternal optimist. So
That's really surprising. Surprising in a way, but also not surprising that the COVID effect would have on vaccines across the board.
well, just a
Thank you.
small PSA about all of this as well. Like our measles vaccine rates have gone down, so now we have measles outbreaks. I don't know the age of people here. My parents grew up in China, and they hated measles, mumps, just these big things on your necks and stuff like that. And so it's also it's not just affecting HPV. HPV is probably one of the first ones to go because it's so new, but it is just all of the childhood vaccines rates have gone down enough so that outbreaks actually happen now for diseases that we haven't seen in like 50 years. So.
I wonder, just last question on the Gardasil vaccine. Do you or is there data that you can speak to about the occurrence of HPV-related head and neck cancer with people who have had the vaccine?
Yeah, very interesting question. I'm trying to use some of the VA data because it's so it's under one system, so you could track people longer through time. Unfortunately, HPV positive oropharynx cancer takes actually quite a while to occur. So cervical cancer happens much more quickly, and we have screening. So when you get a positive PAP, that's probably like 5-6 years before you get cancer. While we don't have that in oropharynx cancer, and so there's not a lot of there's not a ton of research to show the cancer outcome because it takes 20 to 30 years for it to occur. However, there is evidence that if you have an HPV vaccine, you are far less likely to have oral HPV infection, and that leads to HPV positive oropharynx cancer, right? So we know the intermediary is that if you're vaccinated, you far less likely to have oral HPV. You need oral HPV to get HPV positive oropharynx cancer. So there's very, very strong evidence that it dramatically decreases your risk. Hopefully here, let's see, we're probably getting close with the original clinical trials that they use for HPV vaccine to see if we can see a decreased risk. But it's enough evidence already to see that, yeah, you're less likely to have HPV in your throat if you have the vaccine. And so if you don't have HPV, you can't get the cancer.
Thank you so much. We talked a lot about, people who live in certain neighborhoods and certain settings, rural, urban, et cetera. Is there any outreach work that you know of that we're either doing here or just like nationally that you have studied that studies and helps get people screened, diagnosed, treated in order to have better outcomes?
Yeah, so there are some. I'd mentioned like local problems need local solutions, right? And so here we're working on it. I've actually been working with Marcy on making sure people get the not screening so much, but to get people can come to survivorship clinic, or I talked about telemedicine. So how do people feel about telemedicine and being able to go to SLP and to go speech and language pathology, occupational therapy? Like, it's hard if you live far away to come to Oakland, right? And so how do we find people who need to come to Oakland? Can you do some of your therapies virtually, and making sure people have access to the right computers and things to get that done? Mentioned Evan Graboyas out of MUSC. He's really interested in the time between surgery and radiation. And so he has been working with patient navigation. So making sure patient navigators are using patient navigators specifically for people who are not insured, or for people who live in poor neighborhoods who have a need for patient navigation. So really targeting, but he's in Charleston, so that again, that's a different population than here in Pittsburgh. So I'm hoping that as we start building my research portfolio, understanding what are our barriers that our patients are having to get the right sort of targeting, right? We like at this moment, I think it's transportation. I think that's our biggest issue with our patients right now, but this is just me speculating. I think it's transportation, but I'm not entirely certain, and we won't know until we ask and conduct a study. So.
Well, it sounds like there's quite a lot we can expect to see, and more recommendations and guidelines on the way. So, which is good, all good stuff. To your knowledge, how greatly can the quality of cancer treatment vary between people who are in more rural areas who may only have like a local community hospital or regional hospital, or somewhere that we're fortunate enough to have in Pittsburgh, the Hillman Cancer Center, that's kind of like on the cutting edge of treatment? Can care differ very much, between those two settings?
Yes, it does. A lot, actually, especially for something like radiation. So backing up let's talk about surgery. Surgery is fairly confined, right? You come in for surgery and then you stay here inpatient for a couple of days, and then you can go home. assuming surgery goes well. So most people who live in a rural area will come down to Pittsburgh and stay for a couple of days, maybe a week. And that works well. You get treated here. Radiation is a little more complex. Radiation, you have to come in every single day for 6 to 7 weeks. And so that is a very intense treatment. I like to, my radiation oncologist colleague makes me fun of me because I call it torture, because you go into this device and then they irradiate your neck. And it's not easy to do. And so if you live further away, it's hard for you to come into Oakland. And here in Oakland, we have, or not Oakland, sorry, it's at Hillman, so we're shady side. And we have some of the best devices here. We could, if you have a tumor just like right here, they could just irradiate this one little spot here, right? It's very, very specific. We have very complex anatomy, and a surgeon can talk about this a lot more, but the anatomy of your mouth is very complex. And so if you miss even by just like half a centimeter, you could irradiate a muscle that keeps you from like, or to keep you from swallowing properly. And the issue is that in our community, isn't that where that they're not good, is that they don't see enough head and neck cancer patients, right? So here at Hillman, we have 2 radiation oncologists, and all they do is head and neck cancer. So they know how to get the fields just right so that they could irradiate the tumor and miss all of the other pieces. While in the community, they probably see 1 to 2 head and neck cancer patients like a year, maybe. And so then it's hard for them to get the fields right, so that they have this tendency to radiate more, because you don't want the cancer to come back, right? So there's a tendency to radiate more. And so you have more swallowing issues, more speech issues. One of the things we're doing here, Dr. Yvonne Mowry, who's very interested in this, has been working with me on how do we get community care better? How do we get patients 6 to 7 weeks, if you live far away, if you live 2-3 hours away, 6 to 7 weeks, 5 days a week, how do we get patients to come here? Like, how do we get them to stay here in Pittsburgh? And to, it's a long way from home, but your care is much better. So is there a way we can do it that way? What she also does is sometimes she will draw the fields and send them out to the radiation oncologists in the community, and then they know, right? So it's not that they just don't treat enough head and neck cancer because it's a rare disease. So
Very interesting.
Yeah. But and medical oncology is sometimes it's very similar as well. I don't work with it here as much, but in St. Louis, you do see a lot of people getting chemotherapy when they don't need chemotherapy. So in an academic center, you know you don't need chemotherapy, but when you're out in the community, head and neck cancer is rare and it's scary. So a lot of people who do treatment have this tendency to want to over treat. Thus, if you have more chemo, then you know it can cause more vomiting, more neurological problems. So.
Right. And all the other physical symptoms that it can
and it's unnecessary
cause as well. And right. Okay. I think I'll go ahead and ask one more question. We do have a few that I'm not going to ask live, but I want to make a note that I will send them to Dr. Mazul, and if necessary, like a clinician, a head and neck cancer clinician, and they can answer them as a team and send you your answer directly. So I just want to make that note before we ask our final question. And someone asks, for patients who have undergone surgery, chemo, and radiation, is there a guideline as to the recommended return for a re-examination for surveillance, and how does that kind of the post-treatment phase look?
Yeah, so the post-treatment phase, you're supposed to come in. I have to ask this. I also have to ask this every single time, and I just asked recently a survivorship. But so you're supposed to come in the first year pretty frequently for scans. Every doctor is different. Some doctors, and it depends on your cancer, right? So some doctors would be more aggressive and give you a 3-month scan, a 6-month scan, and then a 1-year scan. Some doctors will skip the 3 months and do the 6 months. This is for cancer return. And then after 1 year, it's every year you come in for a new scan. Again, some doctors are a little more aggressive than other doctors. It is very doctor dependent, and something you should talk to your doctor about if you have cancer. From the other part of the survivorship, which is the part I'm actually most interested in, is the speech and language pathology and trying to get a patient back to normal as quickly as possible. And that is also like I think right now their cadence is once a year. Marcy and I have been chatting. It's like, should patients be coming in more? And some patients should be coming in more, and some patients don't need to come in as much, right? So I think the current recommendation is also every year to come in for speech and language pathology and all of this. But I think the cadence could also just be faster. But, you know, coming in that often for lots of care is also very, very, it's burdensome. So
Right.
I think it's challenging, which is where my research takes over. Why are people like, what can we do to lower the bar?
Right.
And like I said, our survivorship clinic is fantastic. You could see 3 or 4 clinicians with 1 copay. So we have lowered the bar as much as we can. And even then and this research I showed was just going to 1 visit. And so Mariana's now going to see, well, are people going to multiple visits? Do people just come to 1 and just don't go to anymore? And so yeah, trying to get back to life. Oh, also primary care visits. Like, people don't tend to go to their primary care doctor either. And post-cancer, it's even more important to see your primary care.
Thank you so much. I also just want to plug, we have such a fabulous head and neck cancer survivorship clinic that you're working closely with. And so, like you said, we've lowered the bar as much as we can. I know the foundation has always been a big supporter of the clinic and hope to continue supporting it, as it grows and changes and all of the great things that we'll do in the future. I want to thank you, Dr. Mazul, for your presentation, for your time. I want to thank our audience for spending their lunch hour with us today. You can feel free to email the contact on your invitation if you have any further questions. We will make sure to answer all the questions that we didn't get to live directly, and we will make sure to post this video of this conversation on our website. So once again, thank you, Dr. Mazul. Thank you, everyone. Have a wonderful afternoon.